Okay. One more question about saturated fat that I think is important. Can we, we're talking about saturated fat, but are there multiple types of saturated fat that we should be distinguishing and thinking about, analogous to the way that we talk about omega 6s versus omega 3s?
Well, in fact, that's right. So, we've learned a calorie is not a calorie. And by the way, an amino acid is not an amino acid. And we've learned a carbohydrate's not a carbohydrate. We've even learned a fiber is not a fiber.
Mm.
And of course, a fat is not a fat. So there are two types of saturated fats, not one, two. There's red meat saturated fats, and then there's dairy saturated fats. And they are not the same either, even though dairy comes from a animal that also provides red meat. So, like, why is that? But it's true. So it turns out red meat is filled with even chain saturated fatty acids, C16 and C18, palmitate and stearate. And those, as I've said, are cardiovascularly neutral.
Got it. Red meat saturated fats, even chained, those are cardiovascularly neutral.
Neutral,
Not good or bad.
not good or bad, neither good nor bad. Dairy saturated fat, so like in milk, turns out to be odd chain saturated fatty acids, C15 and C17. And those odd chain saturated fatty acids have a specific phospholipid signature on their tail end, which is why they stay in solution. Because after all, fat, is in milk, right? I mean, yes, the cream rises to the top, but there's still fat in milk, even after the cream rises to the top. The phospholipid, allows both the oil and the water, if you will, to mix. And so they turn out to actually be protective against cardiovascular disease.
Protective.
Protective. Dairy saturated fat is protective
So,
against cardiovascular disease.
so are you telling us that there's no saturated fats that are clearly negative across the
That's
board?
right. That's right. There are no saturated fats that are clearly negative.
They're neutral if they're even chained,
Neutral.
like red meat, and they're actually protective if they're odd chained, like from dairy.
Exactly right. So you also have to know that, the reason everybody made a brouhaha over saturated fats was this molecule that came out of your liver called LDL. Now,
Mm-hmm.
we've already talked about VLDL. Well, LDL and VLDL are not the same either. Okay. What makes VLDL? Sugar. What makes LDL? Dietary fat, dietary saturated fat. Okay. So there's no question that dietary saturated fat increases your LDL. And there's also no question that in large population studies, LDL levels correlate with cardiovascular disease. That is also true. Okay, the hazard risk ratio for high LDL and coronary heart disease is 1.3. So if you have a high LDL, you are 30% more likely to die of a heart attack than if you don't have a high LDL. Okay, that's real. And I'm not even saying it's not. I totally subscribe to that. 1.3. Turns out the public health community has identified 1.3 as sort of what's necessary for a public health effort. So if it was 1.29, we wouldn't even be having this discussion because we'd be below the threshold. But we're at 1.3. That VLDL that I told you about before, the hazard risk ratio for high triglyceride and coronary heart disease is 1.8. So if you have a high triglyceride, you are 80% more likely to die of a heart attack than if you have a low triglyceride. So which one is worse, the LDL or the triglyceride? Well, clearly the triglyceride. So why are we spending all this time worried about the LDL when we're not even focused on the triglyceride? And the answer is because we had a medicine for it.
Mm. So
We
that's
had
why
patents.
that's why when my mother, my late middle-aged mother, recently went to the doctor and her LDL was high, but her triglycerides looked fine, the doctor was immediately like, you should be on a statin.
Well, that's what the guidelines say. And the guidelines suck because they're not taking into account this whole issue. In addition, there's not one LDL,
Mm-hmm.
there's two.
And we don't normally measure the VLDLs when you go to the doctor. Is that accurate?
Number one, you measure serum triglyceride when you go to the doctor, but there are two LDLs.
Mm-hmm.
So VLDL is its own thing, but there are two LDLs. There's one called large buoyant or type A, and there's another one called small dense or type B.
Mm.
And it's been shown that the large buoyant is the one that dietary fat raises. But the large buoyant, and by the way, large buoyant is 80% of your LDL concentration in your blood. But it turns out the large buoyant are cardiovascularly neutral. That's why I said, for the most part, they're cardiovascularly neutral. Because the large buoyant LDL do not contribute. Number one, they're large. They're so large, they don't fit under the surface of the endothelial cell to start the foam cell formation process to actually drive the plaque. And they're buoyant. They float. So they go through laminar flow in your arteries and arterioles, and they basically don't set up a chance for those particles to be able to actually get under the endothelium to cause problems. So large buoyant are cardiovascularly neutral because they're not contributing to the pathogenetic process of heart disease. Conversely, small dense, they're small. Okay, they're, from an angstrom standpoint, they're about 10 angstroms smaller than the large buoyant, 273 versus 283 microns or so, or angstroms. And they are small enough to get under the surface of the endothelial cell, and they're dense. They don't float. So they fall out of laminar flow so that they can approach the endothelial cell surface so they can get underneath. And then they oxidize, and now you've got oxidized small dense LDL, and now you've got a pathogenic substrate for heart disease. No ifs, ands, or buts. Mm-hmm. So the bottom line is a fat's not a fat. An LDL is not an LDL. Okay. And, this whole concept that we should go fat free to solve the problem actually only created two more. It created both obesity and type 2 diabetes.
Yeah, it created those problems, and it did not solve the one that we thought it would.
Right. So, we need to rethink how we did this and where we came from. And basically, when you make a mistake, you admit the mistake and you right the ship. We have not admitted the mistake and we have not righted the ship. Mm-hmm. And so that's what I spend all of my time basically trying to, get the medical community to, sort of get with the program.
Mm-hmm. So given what you told us about statins and LDL and all that, in your opinion, what characteristics does someone have that justify a statin prescription?
So statins stop you from making your own LDL. Okay. That is true. And by the way, full disclosure, I have been on a statin for 33 years. Mm. Okay. I went on actually I take back, 31 years. I've been on a statin since 1993. And the reason is because everyone in my family has heart disease. My grandfather died at age 44 of a heart attack. My father had his first heart attack at age 61. Okay. Everyone in my family has rampant heart disease. My sister, when 40 years ago, when I worked at Rockefeller, she was a research subject in Jan Breslow's lab. And my colleague and good friend Elliot Britton did a heparin test on her to demonstrate that she had familial hypercholesterolemia. And so do I. I'm a heterozygote.
Oh, really?
Yeah. So okay. I already know.
You have a specific genetic reason for this.
I have a specific genetic reason. So I have been on a statin for 31 years. And I've also tried myself off the statin more recently. And my LDL, popped up from 70 to 300 again.
And how common is this condition? How common are people like you?
1 in 500.
500. Okay.
Okay. So I'm not against statins. They probably, the reason I'm still sitting here talking to you. Okay. For the right patient. And if you have familial hypercholesterolemia, either homozygote or heterozygote, you need them. Okay. So I'm glad they're here. I'm not anti-statin. I want to make that very clear. However, having said that, okay, of the people who are on statins today, which is a whole lot of people, turns out probably 4 out of 5 people who are on them don't need them. They were put on them for what we call primary prevention. That is, they went to the doctor, they got their labs drawn. Doctor said, "Oh, your LDL is a little high. Let's put you on a statin." And the reason is because the guidelines say so. So if you don't put somebody on a statin, you're not following the guidelines. And the guidelines are based on this hazard risk ratio of 1.3. So the question is, for primary prevention, do statins work? We've been using statins for over 40 years now. For primary prevention, do statins work? And the answer is, many meta-analyses have been done, and they all show that for primary prevention, that is, not having had a heart attack yet, just having a high LDL, no event, the mean increase in lifespan for being on a statin is 4 days. 4 days. Now, when you think about the fact that 20% of people who go on statins end up with some level of rhabdomyolysis, the muscle breaks down, they end up with severe inflammation, and 20% have high blood glucose, they have hyperglycemia, because statins interfere with mitochondrial function. That's why they work, to get your cholesterol down. Okay. That's not a good thing. So you were putting people at risk for 4 days of increased longevity and, incurring this huge side effect profile.
So let's just restate this explicitly. When you say you're putting people at risk with a statin, at risk for what's the
for
list of things?
Rhabdomyolysis and hyperglycemia.
Hyperglycemia and muscle loss, basically.
Yes. So, bottom line, if you've already had a heart attack, if you've already declared yourself, okay, or if you have familial hypercholesterolemia like I do, then you absolutely need a statin. And then the data on statin use and longevity is very, very strong and very robust. So for secondary prevention, totally, absolutely sign up. You need it. And if it's primary prevention and you don't have FH, I think this is real travesty.
And if you have let's say you have type 2 diabetes, no personal history of heart attacks, and no family history that's abnormal. It's average family history with respect to cardiovascular disease. What would your general position be on if statins are a good idea for a diabetic?
No. So if you have type 2 diabetes, the first thing to do is get rid of the type 2 diabetes. Everyone assumes that type 2 diabetes is this chronic, unrelenting, progressive, destructive, degenerative process that will never get better. And, you're going to be on medicine, whether it's insulin or oral hypoglycemics, for the rest of your life. That's the general gestalt amongst the cognoscenti in medicine. Garbage. Absolutely not true. Absolutely not true. Numerous studies now show that a ketogenic diet can actually reverse type 2 diabetes. Virta Health, 77% of people who go on a ketogenic diet reverse, not ameliorate, reverse their type 2 diabetes just by getting rid of the offending agent. And what is the offending agent? Well, what is type 2 diabetes? It is extreme carbohydrate intolerance. So if you're intolerant to something, what's the best way to deal with it? Get it out of your diet. That's how you deal with an intolerance. If you are lactose intolerant, get the lactose out of your diet. Okay. Mm-hmm. If you have, if you have peanut allergy, get the peanuts out of your diet. Whatever it is that you have an intolerance to, get it out of your diet. So,
but so
you get carbohydrate out of your diet, you are on a ketogenic diet. And it turns out a ketogenic diet will reverse type 2 diabetes. Now, there are other ways to do it too. It's not like you have to be on a ketogenic diet, but that is one way. And what it does is it is the test case. It is the theory of the argument. Okay, that if you fix the diet, you can fix your type 2 diabetes.
So, I have family members who are type 2 diabetic. They're on statins. They're not given clear dietary guidelines by their physician, except to cut out basically junk food, which by that they mean like candy and things like that. But they're told, for example, eat as much fruit as you want. Does that make sense to you?
Fruit's complicated, but let me try to explain fruit. Okay, so yes, get rid of candy, but there's a whole bunch of other things you have to get rid of too in order to make that right. I guess the question is, okay, get rid of candy. Sure. Is Cheetos food? Is Cheetos food? Yes or no?
Probably not.
It's got calories. It's got calories. Is Cheetos food? So what is the definition of food? That's what we need to know. I mean, so go to the dictionary. I've got one up here if you want. I'll read it to you. Okay. I've memorized it. The definition of food is substrate that contributes to either the growth or burning of an organism. That is food. Growth or burning. So the question is, does ultra-processed food contribute to growth? My colleague, Dr. Efrat Monsenigo Ornan at Hebrew University, Jerusalem, has now looked at this and has shown actually that ultra-processed food inhibits growth. It inhibits skeletal bone growth. It inhibits trabecular bone growth. It inhibits long bone growth. It actually reduces calcium in cortical bone. Okay. It changes epiphyseal function. Okay. So it is inhibiting growth. And we also know it hijacks growth for cancer. Because it basically, fructose in particular does not need to be burned in the mitochondria, right?
I see. So it sounds like you're saying there's an inhibition of natural or good growth, and there's actually, it's actually stimulating pathological forms of growth.
Correct. How about burning? So mitochondria burn, right? Fructose, which is in virtually all ultra-processed food. I mean, it's been added to 73% of the items in the American grocery store on purpose. Okay. It inhibits 3 separate enzymes necessary for mitochondria to do their job. It inhibits AMP kinase, which is the enzyme that drives mitochondrial biogenesis. So you make more mitochondria and fresher mitochondria. It inhibits ACAD-L, acyl-CoA dehydrogenase long chain, which is necessary to cleave the 2 carbon fragments to engage in beta oxidation in the mitochondria so that you can burn in the first place. And finally, it inhibits CPT1A, carnitine palmitoyl transferase 1A, which is the enzyme which regenerates carnitine. And carnitine is the shuttle mechanism by which the fatty acids get from outside the mitochondria to inside the mitochondria. So basically, you can't even import the fatty acids to burn. So, ultra-processed food does not contribute to growth and does not contribute to burning. So, is ultra-processed food food? Is Cheetos food?
What do you
I
think?
knew what I was asking when I asked it.
Yeah.
Bottom line is, we think it's food because it has calories. Can you name something else that has calories that's not food? Alcohol.
Alcohol.
Alcohol is not food. There's no dietitian on the planet who will say that alcohol is food, but alcohol's got calories. It's got 7 calories per gram. How about trans fats? Trans fats are 9 calories per gram. Are trans fats food? Trans fats used to be food. And in 2013, the FDA said, no, actually, they're poison. So just because something has calories doesn't make it food. And that's the key. That's what we have to impress upon the population. And that's a different message than they have been getting for the last 50 years.
Mm-hmm.